This morning. There we go. So good morning to everyone. My name is Paul Bittinger, and I'm the principal investigator for the ASPR funded Region 1 Regional Disaster Health Response System and the Regional Emerging Special Pathogens Treatment Center. And we're really excited to offer a webinar today on surging ICU capacity. Certainly all of us have been through 3 years of COVID and different degrees of surge, and all of us in different ways have had to increase our ICU capacity. But we've got some really great speakers who can talk about some extra special ways to surge adult ICU capacity when needed and pediatric ICU capacity. In particular, of course, this fall, we really all struggled across the country with the enormous surge of cases of RSV in very young children. And that, given where we are with pediatric capacity overall in the country, was certainly a challenge. So really thrilled to have Dr. Hibbert, to have Kim Whalen, to have Dr. Yeager with us, all three fantastic speakers. So if you can go to the next slide, please. So we do have an SMS code that folks can get for attendance and to get accreditation. So always very helpful. I'll just give everybody one more second to write down. It's QAQROX, and the phone number is 857-214-2277. We'll put that in the chat for everybody as well. No disclosures among the speakers. You can see here again the credit that folks can get for physicians, for PAs, for nurses. Hopefully helpful to everybody. We're going to continue this with our webinar series. Next slide. A couple of acknowledgements and disclosures. We really are extraordinarily grateful to the United States Health and Human Services Administration for Strategic Preparedness and Response that funds both the RESPTC and the RDHRS, which are responsible for improving healthcare system readiness for biothreats and for threats overall in the New England area. Next slide. And because of federal funding, we want to make very clear that nothing we say, nothing that any of the speakers says today in any way represents the United States government, Health and Human Services, or any part of it. None of what is being said is meant to constitute medical advice. This is planning advice for healthcare planners. And as already mentioned, what we're offering here is free of financial interests, and there are no relationships to disclose. Next slide. Next slide. So one last time, my name is Paul Bittinger. Really excited to have Dr. Catherine Hibbert, who is the director of the Medical Intensive Care Unit, as well as the vice chair for critical care at Massachusetts General Hospital in Boston. We have Kim Whalen, who is the nurse director of the Pediatric Intensive Care Unit, also at Mass General, and Dr. Phoebe Yeager, who is the chief of pediatric critical care medicine at the Mass General Hospital for Children, again, all in Boston. So with that, we'll move forward. These are the learning objectives that we have for our three speakers. I won't read them to you, but we're really excited to be able to talk about surge capacity in both the adult and pediatric spaces, and talk about how we can get stronger across the New England region altogether as healthcare institutions. So with that, I will turn this over to Dr. Hibbert and really want to thank her again for joining us this morning.
Thank you so much, Dr. Bittinger. It's really my pleasure to be here and to be here with all of you. I'll be talking about something that I think will feel very near and dear to your experience, and look forward to the discussion later. Next slide. This is just the agenda. So I'll be talking briefly about managing surge lessons learned from COVID-19 and what our experience here at MGH and at Mass General Brigham taught us. And then Kim and Dr. Yeager will be talking about how they incorporated some of those lessons into their response to the pediatric RSV surge. Next slide. Next slide. Great. So I don't think I need to tell any of you that our area in the greater Boston metro area was hit incredibly hard by COVID-19 and was hit early. At one point, we were the 4th state or region worldwide after New York, New Jersey, and Hubei province. We had a very high case rate in our area. Next slide. And we experienced that here at MGH. On the y-axis, you can see our MGH COVID census, and on the x-axis, you can see date. This is just for the 6 weeks or so between the beginning of March and mid-April. And you can see that really exponential rise in our inpatient census of COVID positive patients. And that included both COVID positive floor patients, adult medicine patients almost exclusively, as well as a growing census of COVID positive ICU patients and COVID risk ICU patients. And that census continued to grow, and at one point essentially equaled our floor census, in part because the ICU patients had a long length of stay. And so while the floor patients would be admitted and discharged, the COVID ICU patients started to accumulate, and our census really grew significantly through the end of March and beginning of April. Next slide. In response to that, on the general care slide, we had a number of units that were converted to COVID units, and you can see them here and the dates that they were converted to COVID units. I think what's really notable about this is just the pace, the rate of unit conversion, where essentially every 2 to 4 days, we were converting another unit to be a primary COVID unit. And the units that you see here, for those of you who are not at MGH, represent a range of inpatient units from primary oncology units in non-COVID times, urology and ortho units, general medicine units, mixed med-surg units, really neurology floors, really all across the spectrum of what we provide on inpatient care. These units were converted 1 by 1, sometimes 2 by 2, to take care of COVID-19 inpatients. Next slide. Similarly, on the ICU side, again, just when you think about how many patients we were taking care of, the pace was out of our hands, and people really stepped up to meet the charge, and we converted a number of units to be COVID-19 units. Some of these were already ICU units, for example, our cardiac unit and our surgical unit. And in some ways, and I'll talk about this in a few slides, that was an easier ask. Some of these units were not ICUs and were converted into ICUs, including PICU spaces, general oncology floors, really across the spectrum. And you can see there our PICU colleagues also became COVID-19 doctors for adult patients, which I'll talk a little bit about. But again, the pace you can see here was pretty fast, where sometimes there was only a day or 2 between conversions, and we really had to roll out our plan very, very quickly. Next slide. Just to give you a sense of the magnitude of the challenge on the ICU side, before COVID came to our institution and came to our region and to all of our lives, we had an average of about 26 adult medical ICU patients per day, 26 plus or minus 2. Here, each person represents 5 patients, and that was sort of our average census. Advance. This is what our medical ICU census looked like at the peak of our COVID census, where we had well over 200 patients in our units who had COVID-19. This was not the totality of our ICU population. We also had patients with non-COVID problems, emergent medical problems that brought them to our ICUs. But this is just a huge expansion of a population which also required very specific care in a rapidly changing environment. Next slide. We really, and I cannot stress this enough, took a multidisciplinary and interprofessional approach to this staffing. So on the attending physician side, we recruited our critical care colleagues from anesthesia and surgical critical care to become primary COVID-19 intensivists. They already have extensive experience caring for critically ill patients and for adults. And so that, as I said earlier, was in some ways the easier ask. We also worked with our pediatric intensivists, including Dr. Yeager and the rest of her group, and we embedded some medicine pediatric trained residents, or people who are still in their training, into the pediatric ICU to assist in the care of adults in that unit. And so we really were able to work in collaboration to care for patients who traditionally would never have been placed in that ICU. Advance, please. For responding clinicians, we used attendings who stepped back into a responding clinician role, including people across medical specialties, oncologists, hepatology attendings, liver transplant attendings, really people across the spectrum, fellows, residents, CRNAs, So many people across many, many specialties, not just in medicine, excuse me, really stepped up to form teams to care for the critically ill patients who came our way. Advance, please. On the nursing side, we formed nursing dyads that paired ICU and floor nurses together to care for critically ill patients. I think this was an incredible act of courage and service by both nurses in those dyads, and we were so impressed along the way with the care they took of our patients. And there were more than 600 nurses who were redeployed across the hospital to support this. I will also say we had perfusionists who were supporting CVVH teams. We had proning teams, which I'll talk about a little bit more, but so many other care teams were really challenged in meeting the demand of this census of ICU patients. Advance, please. And then for staffing ventilators, we had to use a mix of ventilators, although we were lucky to primarily be able to use ICU ventilators. We also at times did have to use travel ventilators and anesthesia ventilators, and those were staffed by a variety of people, primarily our respiratory therapists who again stepped up with incredible courage and service, but also our CRNAs who stepped out of their normal practice with all of our elective surgeries being shut down, and many of our anesthesiologists. So as you can see, just the number of different people we had to bring together to care for these patients was really astounding. Advance, please. I will also say, and I think many of you on the call also experienced this, it wasn't just the people. There were so many things that went into shortage during this time. Medications, including the things that we were using to sedate patients primarily, as well as, I don't know, medications I never expected to be in shortage, like a meter dose inhaler for bronchodilators, and then many, many elements of what we consider to be essential equipment, such as arterial blood gas syringes, inline suction catheters, our CVVH machines, really across the gamut of the supplies that we use other than medications. Advance, please. And I think we all became very familiar with the phrase supply chain during this time, and it impacted all of us, and I'm sure all of you on the call, but particularly with that large census of very sick patients who go through a lot of disposables and a lot of medications. This, in some ways, had to change our practice. We had to use alternative medications for sedation and reassess how we approached use of disposable things that were in short supply. Advance, please. But we did have some tools that I think helped us be uniquely prepared for this surge and helped us meet the demand that came our way. One is our health systems engineering group. This is just a snapshot of some of the work that they did. You can see on the y-axis on the left-hand side is the number of cases. On the x-axis is date. The bars represent actual census of MGH COVID patients. That's the yellow line. General care patients, which is the blue line, and ICU patients, which is the orange line. The bars represent actual census and the lines represent projected census. So they did some very advanced modeling to help us anticipate based on both what we were seeing in terms of rate of change of census, but also informed by what was being seen in New York, Italy, and China, helped us predict where we might be. And this really guided some of our decisions around rate of unit conversion and how we were going to scale up clinical care teams and support services. Next slide. This is just another snapshot of work by the same group. On the left-hand side is number of ventilators, so our ventilator census at 7 a.m. each day. On the x-axis is dates again, and the dots are our actual census of ventilated patients. The line is the projected census, and you can see here that overall the projection matched the actual census very, very well. We had a small peak above what was projected and then actually started to improve relatively more quickly than was projected toward the end of April. But again, when we were thinking about how many ventilators we needed, where we were going to source the ventilators, and how we were going to staff the ventilators in terms of patient care, work such as this really gave us a leg up and I think helped us provide better care than if we had gone in less prepared. Next slide. We were also, and this feels like a very strange thing to say, but I think we also really benefited from the drop in non-COVID care. And this is really distinct from what Dr. Yeager and Kim are going to talk about next, where they saw a surge in RSV cases and everything else was continuing as usual. During COVID-19, we saw a huge drop in non-COVID census. And you can see that If you look at the blue line on this graph, that is general care, non-scheduled, non-COVID. So those are patients who didn't have an elective surgery that was canceled, but still did not come to the hospital. And you can see just a dramatic drop in patients seeking care and coming in to be hospitalized for non-COVID diagnoses. Of course, our scheduled care, which is the lime green line, also dropped significantly during that time. And you can see the orange and black lines at the bottom, which are dashed black line, which is our COVID census, went up. But we had capacity on these floors to care for COVID patients. We could convert these floors, both general care and ICU floors, to COVID units because they weren't full of other patients. And I think that was pretty unique to COVID-19. And it may not be something that we have in our toolbox in terms of capacity if and when another event comes our way. And I think we saw that with the RSV crisis. I will also say that this came at a real price. And I'm sure many of you on the call, and certainly I have seen many patients who have come in since the COVID-19 pandemic peaked, who've had delay in care and are presenting with more advanced pathology than we would have hoped because they delayed seeking care during the height of the crisis. Next slide, please. We were able to, because we had staff who'd been freed up from operating rooms and other responsibilities, we were able to adapt our staffing to provide unique services to our critically ill patients. For example, we had a proning team. This was a multidisciplinary team made up of OR nurses, OR assistants, physical therapists, occupational therapists, people who were not doing their normally assigned tasks, who really answered the call and became our proning team. They came to our ICUs twice a day, donned PPE, went in the rooms and helped us change our critically ill patients' positions from prone to supine or vice versa. And they really ensured that we were able to deliver a standard of care in our surge ICUs that we otherwise would not have thought possible. Next slide. We also had a really intrepid group of surgeons who were not able to operate, joined by some interventional radiologists and some medicine attendings and trainees who developed a 24/7 voluntary multidisciplinary procedure team who you could call, page any hour, any day of the night, who would come and do procedures on our patients, including central lines, HD lines, arterial lines, and feeding tubes. And again, this was just when we were really at our limits in terms of capacity, both space-wise, staffing-wise, and also cognitively. Having a team that you could trust to come in and help accomplish procedures in a timely fashion really made all the difference. And it was possible because these staff were freed from their other responsibilities by the decreased census in their areas. Next slide. We also had some unanticipated challenges. For those of you not as familiar with the Boston area, our hardest hit zip code was in Chelsea. Advance, please. Chelsea is a primarily Spanish-speaking population. So we had a large Spanish-speaking only population at a time when we were not allowing visitors. This was extremely challenging and I think heartbreaking for so many of us, as well as I think really scary for the patients and their families. And we had a large cohort of Spanish-speaking physicians. We also had a Spanish-speaking palliative care team who became integrated into our teams, helped with family communication. We had a prominent Spanish-speaking surgeon who wasn't practicing his surgical skills and was in the ED every day, enrolling Spanish-speaking patients in therapeutic trials. And I think that in addition to the incredible work done by our community teams and by leadership in Chelsea and other heavily affected areas that were able to flatten the curve, this really helped us serve those patients well. Next slide. Lastly, I think it's important to recognize that the field was rapidly changing. What was considered state of the art for COVID was changing every day. And we had a lot of subspecialties who worked together to try to create guidelines so that our very diverse teams could provide state of the art and evidence-based care to our patients, even as that care changed. Advance, please. And this is just one example. This was our critically ill patients with COVID treatment guidelines. You can see that it is detailed, but also could be put on a single sheet of paper. And again, this was made with a number of different specialties contributing and allowed us to standardize care and really provide best possible care, even as patients were being triaged to different areas across the hospital. Next slide. And so I'll finish my portion just to say that I think there were some COVID-specific response elements. in what we experienced. COVID-19 is a single disease. It does have a lot of manifestations, but it is a single disease. We saw a decrease in other clinical volume, which allowed us to adapt our staffing by utilizing staff from other areas who were less needed. I will say there were other challenges as well, including staff illnesses and making sure that we were keeping people safe. And many people were also caring for their families at home at the same time. And as I mentioned, I think the rapidly evolving evidence is a unique challenge where we were treating a new disease and there was a lot of information out there, some good and some bad, as well as evolving therapeutic approaches. Advance, please. However, I think there are some really generalizable response elements that will serve us well in the future and that Kim and Dr. Yeager will touch on, including use of modeling and health systems engineering for strategic planning, sharing expertise across specialties, understanding that clinical space and clinical teams can be flexibly used, and that sometimes that is the best way to care for patients, even if it takes people out of their comfort zone. I think we learned a lot about how to support those teams, particularly when they were out of their comfort zone, and how to care for one another. And then I don't need to tell anyone on this call, but the regional capacity management was really vital to making sure that no single hospital had ever reached the point of having to turn patients away. And again, I think keeping our eye toward equity always and making sure that we're looking for our vulnerable populations, meeting them where they are, and providing the best possible care, even in challenging times. And so although COVID-19, I think we can all hope will never come back to the extent that it did, and I hope we don't see another pandemic like that, there's many things that we learned that I think we will take forward and that we used this past fall with the RSV crisis. And with that, I will turn it over to my colleagues.
Thank you so much, Dr. Hibbert. I think over the next span of time, I think you will see that the response to the pediatric RSV surge was really built on the shoulders of lessons learned from the response to the COVID-19 surge. Next slide. So many of the measures that helped keep us safe from COVID-19 for 2.5 years, like masking and social distancing, also limited the spread of other viruses like RSV. But as you all know, as people returned to school and work and masking fell to the wayside, these viruses, they came back with a vengeance and without respect for their previous predictable seasonality. Whereas RSV typically shows up in late fall in New England, we started admitting infants with RSV in July and August of the summer of 2022. And by early October, emergency departments across New England started to fill with infants suffering with respiratory distress and hypoxia. They were testing positive not only for RSV, but often for multiple respiratory viruses at once. So the graph you see to the right indicates the very steep rate of rise of RSV-associated hospitalization beginning in early October, relative to what you see in prior years displayed there, where you can see that the onset of the RSV season started later and with a much less steep rate of rise in many years. So for Mass General for Children, which is the children's hospital embedded within Mass General Hospital, we quickly found ourselves overwhelmed by requests for ICU beds. With only a 14-bed pediatric ICU, we felt pressure to graduate patients from the PICU to the pediatric ward sooner than usual in order to make room for new infants with more severe respiratory distress. And not surprisingly, a byproduct of this was an increase in rapid response calls on the general care wards. As you know, the mainstay of therapy for RSV bronchiolitis is supportive and often includes things like nasogastric tube feeds, IV fluids, airway suctioning, and supplemental oxygen. But for infants with increased work of breathing, we often utilize high flow nasal cannula and non-invasive ventilation. And it's pretty rare that infants require intubation and invasive ventilation. In our hospital, we've had a pathway for several years that allows for the use of high flow in infants with bronchiolitis on our general care wards. And during this most recent RSV surge, this capability allowed us to keep many infants with bronchiolitis out of the ICU and on the wards. The problem, however, was that a subset of these infants failed high flow and required escalation and respiratory support to non-invasive ventilation. And we recognize that delaying this escalation while waiting for us to try to open up a PICU bed place these babies at risk of further deterioration, including the need for more urgent or emergent intervention for impending respiratory failure. So we quickly stood up a program supported by our tremendous respiratory care services to initiate RAM cannula CPAP on the wards while trying to make a bed in the PICU. And over time, as you're going to hear more from Kim Whalen, we stood up an intermediate care unit that enabled patients on CPAP and BiPAP to actually safely remain on the wards. Similar to the deteriorating patients on the wards, prolonged wait times in the emergency departments, both in the community and our own ED, really stretched ED resources and sometimes ended up resulting in a delay in care and clinical deterioration, so that when patients arrived to the PICU, they were sicker than perhaps they might have been had they come sooner. The number of calls from outside hospitals requesting PICU beds soared, and we had to refuse many due to limited beds early on in the earlier days of the unexpected surge. Next slide. So while some focused efforts on building new pediatric ICU space, at MGH, I think we learned from the COVID surge that making new ICU beds is fraught with challenges. Opening new beds doesn't necessarily make the care better. One needs streamlined processes, role clarity, partnerships that tap into different providers' expertise, and staff support models that can safely extend the capacity of nurses, physicians, and other providers. As you heard from Dr. Hibbert, during the initial COVID surge, our PICU pivoted to caring for adults with COVID ARDS. Faced with the dual challenges of transitioning from treating children to treating adults and implementing dynamic COVID-19 care recommendations, we quickly recognized that preserving our team composition minimized unnecessary changes in personnel and environment, and ended up being an important factor in our success. We also recognized immediate gaps in knowledge and skills related to providing adult critical care, and we leveraged the adult medicine expertise at our institution. So we had pediatric intensivists and trainees who remain the primary providers, as you heard from Dr. Hibbert, in the unit, with medicine resident and adult intensive care unit consultants reviewing patient plans and helping to support us. We created PICU and floor nurse dyads, much like they did on the adult side. Basically to extend the reach of our expertise. And we also tapped into ICU nursing expertise on the adult side with a warm line for further support. The photo on the right shows the adult pediatric hybrid rounding team outside a patient room in our unit back in April 2020. So as you've heard, the adult intensivist provided ongoing online and in-person education and things like the pocket guide that you saw to ensure that regardless of the ICU location of an adult with COVID ARDS, the same level of care would be provided. As you're going to see in the next few minutes, we employed many of these same strategies used during the adult COVID surge when the tables were turned and our adult ICU colleagues and others less comfortable caring for critically ill pediatric patients stepped up to help us address the pediatric RSV surge. The lessons that we learned and the relationships that we strengthened with our adult MGH colleagues, as well as PICU colleagues across the region during the COVID surge, positioned us really well to respond to the RSV surge and safely meet the needs of our pediatric patients. Next slide. So beyond the work we did internally, we also partnered with the public through traditional media outlets and social media platforms to provide transparent communication around the capacity crisis, and also to set realistic expectations related to things like longer wait times in the emergency departments, and also the fact that the trajectory of this surge was somewhat unknown. We tried to empower the community through education about RSV, how it's transmitted, when it's safe to care for children at home, and when to seek medical attention. And this we did in the form of handouts, webinars, press conferences, print media, and local TV news programs. Next slide. So we ensured that handouts like this, and you can advance, were readily available to families, not just in English, but in other language spoken by many families in the community, including Spanish, Arabic, Portuguese. So with that, I'm going to turn things over to Kim, who's going to talk more specifically about how we stood up a pediatric intermediate care unit to expand our pediatric ICU capacity.
Thanks, Phoebe. So as the RSV surge started to escalate, multidisciplinary teams at Mass General started meeting to discuss the solutions for the unique challenges the RSV surge presented. We had learned from our experience with COVID how important it was to focus on the above principles of disaster management. We knew it was important to focus on how we could utilize and optimize the space, staff, supplies, and systems for the surge of pediatric patients we were starting to experience at Mass General and throughout the community. Next slide. We wanted to highlight some of the best practices for creating a pediatric surge intermediate care unit. Reviewing patient placement and cohorting patients became extremely important. To meet the acuity and volume of RSV pediatric patients, the pediatric floors transitioned their general care beds to support higher acuity patients. Initially, the respiratory patients were all on, they were on 2 floors in the pediatric wards. And it was quickly realized it was beneficial to cohort all of the pediatric respiratory illnesses onto one of the pediatric floors for conservation of staff and resources. This also enabled respiratory therapy in the PICU staff to provide support to one location. And as the surge quickly ramped up, staff were being pulled in many different directions. So cohorting the respiratory patients enabled the pediatric staff and respiratory therapy to focus education, training, and support. Another aspect we found that was beneficial was creating criteria for placement in the PICU versus the IMCU. As the higher acuity patients continued to come into the hospital with limited PICU beds, we worked with the pediatric multidisciplinary teams to develop criteria for higher acuity patients on the pediatric floors. At this time, we were faced with a full PICU, patients on the floor escalating in acuity, and patients in the ED requiring a PICU admission. Due to the capacity challenges, it was vital to create new criteria for patients being admitted requiring non-invasive and continuous albuterol, patients on the floor requiring escalated care. Typically, these patients were requiring a transfer to the PICU, but there was no beds, and patients transferring to the floor from the PICU. This may be a patient who was improving, but still requiring CPAP, which normally they would have stayed in the PICU. We were constantly evaluating the acuity of the pediatric patients throughout Mass General to determine placement. And we discovered during COVID that patient selection was crucial in ensuring the best care for the patients. One of the other things we did was created a Volt communication for capacity challenge. This allowed constant communication between the PICU, the floors, respiratory, supervisors, and capacity to ensure the right patient was in the right location. In creating the IMCU, we learned if these patients were to be placed on the floor, there needed to be a way to integrate the ventilators. The pediatric floors worked with respiratory, IS, biomed to implement alarms for the ventilators and Epic integration. Next slide. The pediatric staff were being pulled in many different directions, and one of the other lessons learned from COVID was it was beneficial to tap into resources and staff in different ways. As the PICU transitioned to an adult COVID ICU, the PICU nurses were supplemented with adult general care nurses to provide care. The team was able to work together to provide the best care to the adult patients. During the RSV surge, the pediatric floors implemented a nurse extender role. A call was put out to nurses with any pediatric experience from various areas to assist during the surge. These nurses worked with the pediatric floor nurses to provide care. We also supplemented with some pediatric travelers that were also very in high demand across the country at the time. One of the unique roles that we created was the PICU consult RN. It was important to the PICU nurses to support our colleagues at Mass General and in the community. We had learned during COVID how vital it was to have the support of our adult colleagues to care for this new population. And in the PICU, we felt we were experts at RSV in providing care to these patients and wanted to be able to provide resources and support to the patients' families and colleagues in need to ensure safe care of all the pediatric patients. So I put out an email asking if staff would be interested in this role. And by the end of the day, I had staff signing up to do extra shifts, overtime. They all wanted to make sure we could help as many children as possible. What the PICU Consult RN would do was provide hands-on support to the pediatric nurses with suctioning, chest PT, airway clearance, help clarified and facilitate communication between different teams managing the patient. They regularly rounded on patients outside of the PICU. They provided education to the pediatric floors, and they also would stay with a patient when the PICU was full and there was no PICU beds. The PICU consult nurse would go up to the floors and stay with that patient until we could figure out how to get that patient down to the PICU. The other coverage that was added to the IMCU was the PICU attending overnight coverage. The PICU attending added additional support to the pediatric floors overnight to help with these higher acuity patients. And it was also important to add a dedicated respiratory therapist to the floor to cover these respiratory patients. They provided support and education to the staff who were not accustomed to caring for these higher acuity patients, often on non-invasive ventilation. Next slide. So some of the staff education that we did, as mentioned previously, we created guidelines and educational material for non-invasive ventilation and continuous albuterol. We created QR codes, and the information was placed on the MGB site so everyone could have access to this material. We had started working on this for the pediatric floors, but as the needs grew, we realized that the community hospitals were also looking for this information. So we wanted to make sure that everyone had access to this. Next slide. So this is just a picture of the pediatric nurse up on the floor with the PICU Consult RN and respiratory therapy, and they're just doing a simulation on non-invasive ventilation and suctioning and how to reposition and tape the cannulas. Next slide. As many of us knew with COVID, staff wellness and support was crucial. Many of the staff had been on the unit during the PICU transition to the adult COVID ICU, and the RSV surge brought up many similar emotions. The one difference that staff felt was we knew RSV and we knew how to treat it. So the emotions were more around the lack of resources for all the pediatric patients requiring care and how we could help. During COVID, we had one of our child psychiatrists who would make well-being rounds on the unit. She would casually walk around the unit and created space for staff to talk about the challenges and frustrations. And she offered her support again during the RSV surge. Staff found this so beneficial to have someone they knew and trusted taking the time to support them. We were also able to bring in pet therapy and Reiki support for the pediatric units during this time. And one of the things that we did between the units was just showing appreciation to all the teams working together to provide care for these patients. Leadership and the staff would send meals and treats to each other just to let each other know that we appreciated everything everyone was doing. Next slide. So during COVID, we knew it was important to maintain the correct supplies for the patient population. Mass General Materials Management worked with Mass General Pediatric Leadership and MGB supply chain to ensure supplies were monitored and ordered appropriately and in a timely fashion. We looked at the PICU supplies to evaluate and make sure the floors had the same materials that they needed up there. We increased the supply levels for all pediatric units. Closely monitored respiratory equipment supply needs at Mass General and across the system. This included deploying an increased number of ventilators for CPAP to the community hospitals within MGB. During this time, as Catherine had mentioned, we were also faced with medication shortages. Pharmacy implemented strategies for shortages on amoxicillin and albuterol and published communications for staff to mitigate these different shortages. So initially, pediatrics was working within pediatrics to handle the surge, but as the surge escalated, pediatric leadership continued to work on capacity challenges in education, but it quickly became clear we needed increased support. We learned from COVID that not only was clear communication vital, but also having the support from Mass General and MGB was essential. At this point, the hospital command system was activated. The activation of the hospital incident management team elevated the concerns of pediatrics and enabled many initiatives currently being worked on to be quickly implemented. This created unity and support with the MGB system, and it allowed resources to be distributed throughout MGB and created clear communication for all of pediatrics within the organization. I'm going to turn it over to Phoebe now.
Great. Next slide. And the next slide. Thank you, Kim. So as Kim just highlighted, the ability to safely care for infants with RSV requiring non-invasive ventilation on our pediatric wards, it expanded our ICU capacity by about 50% and enabled us to say yes to more ICU bed requests from EDs across our referral system, but it fell far short of the need. Based on standing Zoom meetings orchestrated by the Massachusetts Department of Public Health with nurse and physician leadership from all the PICUs in our state, we knew more had to be done. Dr. Garcia, the CMO for the Mass DPH, he was on these PICU leadership calls, and he also grasped the magnitude of the bed crisis, resulting in this memorandum that was distributed, you can see on October 31st. The subject was guidance on the management of pediatric respiratory illness patients during times of capacity constraints. And in it, Dr. Garcia highlighted two important directives. First, he urged hospitals to consider admitting infants to the neonatal ICU who ordinarily would be deemed too old for this environment. And second, he reminded providers that patients who are 15 years old and older can be admitted to adult wards and ICUs, provided that pediatric expertise is available for consult. This important memorandum provided the framework and the reassurance needed to consider placement of appropriately selected pediatric patients requiring ICU care in ICUs beyond the pediatric ICU, supported in a similar fashion as was done for our adult colleagues, as was done by our adult colleagues during the adult COVID surge. Next slide. And again, just as was done during the COVID capacity crisis, we recognize the importance of sharing the magnitude and the dynamic nature of the pediatric bed crisis. Situational awareness across the hospital and system helped garner support for our efforts and gave us a better understanding for what our community partners were experiencing, and reminded us that we were all part of a single system with the shared goal of getting patients to the right beds as quickly and safely as possible. So this is just an example of the daily snapshot that was sent out to all MGH providers, as well as providers across our referral system. Next slide. So Mass General has 9 ICUs, and just as we had done during the COVID surge, we concentrated efforts on flexing existing clinical space to best accommodate the surge of pediatric ICU patients. We developed a triage process to help direct patients to an appropriate ICU, and we use specific patient selection criteria, things like age and weight and diagnosis, similar to the triage process that was developed during the COVID surge to figure out the right ICU space for the right patient. But what I really want to emphasize is that optimizing the use of existing ICU space required far more than careful patient selection and streamlined triage processes. Our goal, again, was to make sure that regardless of the ICU location of a critically ill pediatric patient, they and their families would receive the same standard of care. Next slide.
Thanks, Phoebe. We wanted to ensure that patients were requiring the same care regardless of location. There were now higher acuity patients in the PICU, on the pediatric floors, in the NICU, and adult ICUs. So we created guidelines with the adult ICUs to ensure that there was consistent family-centered care regardless of location. We worked with the adult ICUs to ensure family-based rounding and pediatric visitation policies were the same. We created communication to inpatient families to explain that family-centered care would be provided to their child throughout MGH. And we ensured that these units would have access to PICU, MD, RN consults, pediatric pharmacists, child life, and pediatric social workers. And as mentioned in the triage guidelines, we would assess the patients greater than 15, triage to the adult ICUs. And as COVID taught us with the adult COVID patients in the PICU, patient selection was important. It was important to not only triage by age, but consider other factors such as the weight of the patient. There were many weight considerations with medications when a patient is under 40 kilos. So it was also important to make sure all the units had a pediatric code card in an emergency response. Next slide.
So beyond guidance regarding placement of appropriate PICU patients in other ICUs, the October 31st Mass DPH memorandum gave two specific directives regarding pediatric emergency department and inpatient care in the community. First, the memorandum called upon all general EDs to develop and implement high flow nasal cannula oxygen capability. And second, the DPH encouraged all pediatric hospitals with pediatric expertise to develop a teleconsulting service to support their referral hospitals. We were able to leverage the strength of our hospital network called Mass General Brigham to stand up both of these services quickly through provision of education, equipment, connectivity, and pediatric expertise. Our respiratory care team deployed high flow nasal cannula equipment to some of our community hospital EDs, and importantly, paired this with education. Next slide. Video-based demonstrations, tutorials, and lectures about RSV management and the use of high flow and non-invasive, as well as patient resources in multiple languages, were posted on MGB's Central Enterprise landing page. This was the same system previously used to disseminate guidelines and educational materials and other resources during the COVID surge. Having a single, easily accessible central repository for this kind of information was invaluable. Next slide. We were also able to take advantage of pre-existing telemedicine infrastructure to establish a PICU teleconsult program for our referral hospitals. Consults on patients in community hospital EDs were used to help evaluate and triage patients and provide guidance on initiation of high flow to prevent deterioration while awaiting bed placement. Consults on patients already admitted to a pediatric ward were used to provide advice when patients weren't doing so well and to help determine whether to transfer into the PICU. Lastly, consults to adult ICU providers in the community enabled them to hold onto some teenage patients and avoid having to send them into Boston. The consults were multidisciplinary. They included PICU nurses, respiratory therapists, and intensivists. And for the most part, we relied on existing telecarts in the community previously used for our teleneurology program. Using our central credentialing by proxy system, it was relatively easy to get all 12 of my PICU faculty credentialed to provide teleconsults. And in one case, we were able to obtain expedited temporary licensure to provide teleconsults in a hospital located in another state. The photo that you see here shows a teleconsult I provided for a baby admitted to a pediatric ward in the community. The baby had been admitted the day prior for dehydration in the setting of RSV bronchiolitis, but had gone on to develop respiratory distress requiring high flow nasal cannula. The local hospitalist requested the consult because she was concerned the infant was tiring and working too hard. You can see the MGH PICU team in the small window at the top of the screen, and it included, in addition to myself, one of the PICU fellows, one of our respiratory therapists, and one of our PICU nurses. On the other end, you can see the baby, but beyond the baby, we also were able to engage with the bedside nurse, the hospitalist, and the baby's parents were there too. Seeing the infant, we were able to suggest upsizing the RAM cannula prongs for a better fit, and we were able to reassure the local providers that the infant didn't appear to be tiring and could continue to be safely cared for at the outside hospital. The parents were relieved, and we avoided an unnecessary transport into our last available PICU bed. And that bed was later filled with a critically ill infant who was requiring invasive ventilation. Next slide. So directors of the 5 PICUs across Massachusetts first started meeting regularly in response to the COVID pandemic to improve situational awareness, disseminate new knowledge, and share clinical guidelines and approaches to capacity challenges. And even after the worst of the COVID pandemic had abated, we actually never stopped meeting. And this positioned us really well to continue to collaborate during the RSV surge. We joined statewide weekly capacity and load balancing calls led by Dr. Garcia from the DPH. And we used this time to report out what we were seeing and the various challenges we were facing. We discussed various strategies for addressing the capacity crisis and shared resources we were developing to support our teams and community. One area we tried to streamline was the system used by community hospitals to find available PICU beds. People lamented the duplicative efforts that were being used to identify beds, and we worked with our 2 state-sponsored critical care transport services to create efficiencies. And we committed to working together to ensure that no patient in Massachusetts in need of an ICU bed would ever be sent out of state, something unfortunately that had occurred early on in the surge. Having the ear of the DPH was extremely helpful, and we urged them to use their position around managing to the community. And with support from the US Health and Human Services Administration for Strategic Preparedness and Response, we used a similar model of weekly pediatric calls, including all 12 PICUs across New England, as well as representatives from ASPR and each state's DPH. And through this, we were able to maximize situational awareness across the region and share lessons learned and strategies. The calls often served as an early warning system regarding things like medication and formula shortages. And we spent a lot of time discussing the challenges, again, of identifying open PICU beds. And so with ASPR support, we were able to develop a regional capacity dashboard referred to as Region 1 Pediatric status update to aid community hospitals searching for PICU beds. Next slide. This is a screenshot of the board that was updated a minimum of twice a day by each hospital with both pediatric general care and ICU bed availability. It indicates when a given hospital is accepting transfers and who to contact. And this was available to all referring EDs across the region. And the goal obviously was to minimize time spent identifying beds for pediatric patients. In reality, the system was just getting off the ground when the surge subsided, but the infrastructure now exists and certainly could be used in the future. So next slide, you all know the punchline to this story. You can see it here in the graph on the left in green. As quickly as the massive RSV surge swept across the country, it dissipated by mid-December. During our system-wide debriefing of our response to the surge, many lauded the response that took advantage of systems and lessons learned from the COVID capacity crisis, some of which I've tried to highlight for you. But we also reflected on areas for improvement, including earlier activation of our incident management team. Some of the systems set up to address the surge were just coming online when the surge began to ebb. So of course, none of this work is futile. And if there's anything we've learned over the last few years is that there will be future surges, and the hard work that we put in to establish workflows and streamline systems of communication will hopefully position us well for the next time. Next slide. And while the RSV surge may have passed, significant adult and pediatric capacity constraints persist across our hospital and the region, but gone are the days when our pediatric and adult services operate independently from one another. The adult COVID surge, followed by the pediatric RSV surge, brought our services together into a single, tightly integrated system of care and showed us that with proper workflows, education, collaboration, and sharing of expertise, we can flex the use of our existing clinical space to safely accommodate the dynamic demands for ICU beds in our community across the age spectrum. And beyond our own hospital system, we learned the importance of early and frequent communication and collaboration at the regional level to improve situational awareness and coordinate our response in a way that, again, optimizes the use of existing space while ensuring that patients receive consistent care regardless of their location. Next slide. So thank you so much for your attention, and I will turn things back to Dr. Bittinger.
Thank you so much to all of you. It really was a fantastic talk, and hard to believe, it's possible to encapsulate so much work in such a short period of time. I think we sadly are not going to have enough time for all the questions that I definitely want to ask, but maybe Kim, if I might start with you. I think there was so much great content presented on not just what was happening to surge the PDICU capabilities themselves, but the intermediate care unit that you mentioned. And I think I've certainly heard about an evolution in the nurse's comfort level outside of the PICU in caring for patients with acute respiratory illness. And you outlined that there was respiratory support, there was PICU nurse support, there was physician support. But can you just talk a little bit about that journey of sort of how the nurses outside of the ICU changed in their sort of comfort and confidence level with the resources that were provided?
Yeah, absolutely. I think when everything first started happening, things just escalated really quickly. And I think the nurses on the floor knew that they didn't have the skills but they wanted to provide the care. So I think by providing them the support and the education, they wanted to do it. They wanted to learn, they wanted to provide that care, but it was important that they had the education and the support, because without that, they just felt, that they weren't providing the best care possible. So, I think by supplementing with the PICU nurses, respiratory therapy, having the attending PICUs up there on night, it just really made the difference for those nurses.
Yeah, excellent. Can maybe I'll leave it open for all three of you, but maybe Catherine, if you can start, and then Phoebe next. But what types of monitoring were used as you expanded ICUs, both expanded ICUs in spaces that were not previously ICUs, and then for getting back to the intermediate care question, how were you monitoring patients in areas that weren't designed for ICU monitoring?
Yeah, I can talk about that definitely. I think I would divide it into sort of two areas of work. One was the acuity on our general care floors went up significantly at the same time that there were general care floors for adult medicine patients where medicine patients don't normally stay. So we were with, nursing teams and physician teams who were less familiar with progression toward respiratory failure, just as we were placing more patients who were sicker on those floors. So we expanded our triage and evaluation teams, which we do in coordination with our medicine residents who go around and assess patients who are getting close to needing an ICU. And that was really helpful in trying to identify patients before they were emergently needing to go to the ICU. We also established criteria around, for example, dose of high flow nasal cannula that patients could be on outside of the ICU, so that we triggered triage automatically in some cases. For units that were converted into ICUs, we worked really hard with our biomedical engineering colleagues to try to integrate as much as we could into the monitors. The one thing that we really struggled with was getting ventilator alarms integrated into central monitoring. And we actually utilized staff who, including, like PhD postdocs who weren't able to go into their labs, as vent watchers who truly just sat outside rooms and looked for ventilator alarms and then alerted the clinical team when an alarm went off, because that was something that we just could not get integrated into our central alarm system quickly enough. So a combination of really hard work, some just boots on the ground from willing and really able volunteers to be ventilator watchers, and then trying to move patients sooner rather than later when they were getting sicker, and expanding our triage teams to monitor patients on the floors.
Excellent, thanks. Phoebe?
Yeah, I think that we just stood on the shoulders of that work. We've worked very closely with bioengineering to really have monitors and alarms feed into our central nurses station up on the wards for the IMCU, and then of course the ratio of nurse patient ratio also helped, having more eyes on fewer patients.
Yeah, excellent, excellent. All right, I regret that we are already right at time and the hour flew by, but I really want to thank Kim, Dr. Yeager, Dr. Hibbert. Thank you so much. This was great content. For everybody who has attended, please do claim your CME CEU credits. This recording will be archived and recorded, posted on our RDHRS website. So please go to www.rdhrs.org or send colleagues who you think might want to watch this webinar to that location. It'll be up within about 24 hours or so. But thank you again. Hope this was helpful to everybody, and we wish you all the best.